But I'm going to now continue with the next session because there are three terrific speakers who have to be heard. So the last interesting session is the video-based pearl, and we have with us in the session our very eminent Dr. Gopal Pillai, who's a professor and head of the VR surgery department at Amrita Institute of Medical Sciences, Kochi. His interests are diabetic retinopathy and vitreous surgery, and he's going to talk on a very interesting topic, bullous retinal detachment in AC, and his discussant would be Dr. Reema Bansal. On to you, Dr. Gopal.
Thank you, madam. I'll share my screen. I hope I am audible and the screen is visible.
Yes, yes.
Yeah. Okay,
yes,
so this is a patient with accident and loss of vision. There was a corneal perforation which is repaired. And then what happened is there is this corneal opacity after primary corneal repair, and a penetrating keratoplasty was done. And after the penetrating keratoplasty, things were good. And the patient had about, post-PTA 1 week, good visual recovery. Then there was a total retinal detachment, and you can see that the retina was there right in the anterior chamber. So let us go into the surgery of such a condition. So the first pearl is that if you have such a significant retinal detachment into the anterior chamber because there is aphakia, we can always use a AC maintainer. So an AC maintainer will keep the pressure and use the other side to make an opening, and so you can definitely remove this air bubble and then enter. So this is another AC entry through which you can use the other side instrument, the vitrectomy probe. So here there is no maneuvering space. So you are basically using whatever space is there to cut the vitreous, but you can see that here there's a tear also here. And you can see whenever we are trying to do any vitrectomy, the fluid is going through the tear to make the retina more bullous. So we are using a silicone tipped instrument to remove that subretinal fluid. Now I could have used a pupil expander device, but post-operatively, since we require a dilated pupil for examination of probably laser or whatever reason, so that is why I decided to use a vitrector to cut the iris to make the pupil a little larger. And you can see that once you have made the pupil larger, you get a little more maneuvering space. You can change it to a 3-port thing. So you can see this also. This AC maintainer should never go outside, because if it goes outside, then you have your instrument inside. If it is a vitrector inside, you are doomed because there will be choroidal detachment. Once we enlarge the pupil, probably we can move into the 3 ports again. So as we can see here, we have moved into the 3 ports. And now, we should basically take care to move anterior to the retina and not cut through the retina. So we have to move very anteriorly, almost just behind the ciliary body. And then I am trying to do vitrectomy there as much as possible. But as you can see, the maneuvering space is too low. And that is a point of time then we decided that we will use some PFCL so that the bullous retina just comes down a bit. And so we will be able to have some maneuvering space to do the rest of the vitrectomy. And this is the needle that goes inside, and under visualization only. So we will probably initially there was some PFCL which was injected, and then under visualization the rest of the PFCL was put. You can see the PFCL here, which is opening the retina, and the bullous retina is going outside. But you see, in such a situation where you've not done a complete vitrectomy and then you are trying to do a PFCL without seeing the tears, you have this possibility of subretinal PFCL. So, subretinal PFCL can go in through a smaller tear, but if oil has to come out, it has to come through a bigger tear, because oil almost always moves at a bubble. So you should always make an opening more peripherally, and as much as possible more superior. Okay, because superior retina can be easily tamponadable by oil, and that is how we have actually enlarged that tear a bit. And then you have to basically open up, because PFCL goes into the most posterior most recess, and so you will probably have to open it up and then go into the posterior pole, probably near that macular area, to remove the PFCL. In this point of time, it is always better to have more intravitreal PFCL in a place that so that it can be milking out. So now we have completely filled the eye with PFCL after doing the vitrectomy, and the peripheral vitrectomy is done. Now you can see one tear is superior, one small tear is inferior. And here we are doing the laser of that inferior tear, and then the superior tear here, that is a superior peripheral tear. And in such a situation where there's a PFCL inside the eye, it is better to do direct silicone oil PFCL exchange. So here you can see with the left hand, I am basically removing the PFCL. This is a small bubble of PFCL, which you can see is reducing. And with the right hand, I am injecting the oil. And once I completed the oil and the retina is completely attached, I'm completing it with more laser. And that would be the end of surgery. So here is a case in which there's a very high bullous retinal detachment, in which we had started with the anterior chamber maintainer, but then later on moved into 3-port vitrectomy and used PFCL. PFCL went subretinal, removed the subretinal PFCL, and completed the vitrectomy. This is final pressure. Pressure is basically adjusted. We should make sure that the oil does not come into the anterior chamber through the aphakic area, and we should have adequate protection. That is it. So thank you very much.
That was a brilliant, very valiant surgery. Hats off to you, Dr. Gopal. Yes, Srinivas, your comments, and we go on.
I think we'll first hear from our expert panelist, Reema Madam.
Well, I think very heroic surgery.
Heroic is the word. Yes.
Yeah. So I think somebody even would just let go this patient off, because bad cornea to begin with, and then a good penetrating keratoplasty, and then the retina lying there. Surprisingly, there was no GRT, but intra-op, so many things to handle, and everything turned out to be. Just for my interest, do you have the post-op follow-up of this patient?
Yeah. This patient had initially 636, dropped down to 6/60. I think I may have a redetachment if I remove the silicone oil, so I'm keeping it right now.
Oh my God, 636, too good.
No, it reduced to 6/60. I don't know. Moving forward, there are lots of problems, secondary glaucoma, because it is an aphakic patient. A lot of problems, but young guy, let us see.
No,
I had
wonderful.
one question. Gopal sir, since you were trying to settle it down and it was not settling down when you were trying doing through the anterior face of the hyaloid. So what if you had done an external drainage and tried to settle the retina? It's another chance where we can definitely settle it down. I have never tried that doing it, but I have seen
I think
many
Mahesh sir has tried it multiple times. I think I would like to hear it from him. Mahesh sir is here. What I think,
I'm here.
Yes, sir.
Yeah, that's what I was thinking when you were showing the video. I would have probably used a needle, transcranially, transconjunctivally, and the infusion through the anterior chamber would have pushed the fluid down. When the bullosity of the detachment decreases, then sometimes what I do is I just inject PFCL through the anterior chamber also. That goes to the posterior port, pushes the retina down. Of course, it's over the hyaloid, and subsequently can go ahead and complete the vitrectomy.
That is what I did. I just put in PFCL through the anterior chamber into the retina, but it was very bullous. Probably there was because of the bullous nature, there was a very posterior break, and probably it went in through that.
Yeah, correct. All you have to do is to temporarily go into the conjunctival cul-de-sac with a 26 gauge needle with the plunger removed, go inside, and then the subretinal fluid will come out through the needle and it will go back. Yeah.
Okay.